this age group. It should be in your prime. And females as well. So again, just generalities there. This talks more about the example. Again, a bunch of math here. Do not worry about all that. Much more concerned about you knowing what it is and how to get there with it. So yeah, nothing to worry about there. This is important. We'll talk about this today. We talked about it before. This FIT principle. Okay? How do you affect exercise? You can be affected by all of these factors. But frequency is huge, obviously. This is the American College of Sports Medicine's recommendations. Intensity, obviously, this can be varied, depending on your patient. Time and duration, obviously, a very easy thing to manipulate. And the type, the mode, things you're going to read about mostly when you're dealing with cardiopulmonary types of things. Large muscle groups, we talked about that before, how stationary bicycle versus UBE, much larger muscle groups. Okay? You can burn a lot more calories. You can make things work a whole lot, make your heart work a lot harder here than you can over there. Not that that's bad. It's really good to mix these things up. So, has anybody been to a cardiac rehab lab? Okay. I would love to take you guys to one, but they won't let us in, unfortunately. COVID has put the clamp on all those types of things, unfortunately. Every exercise session should include a 5 to 10 minute warm up. Completely agree. This would include some stretching, as well as a 5 to 10 minute cool down with stretching. Okay. Gets them in good habits there. Yeah, you're gonna hear that. Any questions on her lectures? Again, big picture stuff, big picture. All right. So the guy that did these lectures for me before, he's in North Carolina, a good friend of mine. He is a guru when it comes to George Felford, when it comes to cardiopulmonary. He is a cardiac certified specialist. Not many of those in the world even. As a PTA rep. So he put this together, and then last year when I tried to get him to do this via Zoom, and he's always traveling the world and stuff, he couldn't do it. So we sat down and put this together. I'm not an expert, but I know enough to help you guys through this and get big pictures types of things. So in terms of exercise testing, that's what you're going to see in these labs and so forth. Non-invasive. Nothing's getting inserted into anybody. They may have to wear a mask for VO2, but again, nothing invasive. Not that it's not hard though. Okay? Provide lots of different information to the referring physician, who's going to make lots of decisions based on that information. Exercise testing and functional assessment really aren't that far apart. I mean, we talk a lot about functional assessment and orthopedics and so forth. Exercise testing is really pretty close. You're just looking at aerobic capacity during ADLs, ambulation, and outcomes. All right, so who needs to be tested? This is something that you guys should know. Men over the age of 45 and women over the age of 55. Obviously, you ladies, you have less cardiac issues than men. Anybody with a family history of cardiovascular disease. If you're a smoker, definitely. If you are have sedentary lifestyle, If you are obese, and this is the classification, the BMI, body mass index we talked about, if that's over 30, okay? Hypertensive. Now there's some leeway on this. You'll see ranges for pre-hypertensive, stage 1, stage 2, all that kind of thing. Again, I would know generalities there, right? We talked about lipid scores, right? High density lipoproteins is what you want. If this is below 40, this good cholesterol, that's a problem. That's a risk factor. LDLs, over 120, another risk factor. And your total triglycerides, that's over 150, that adds to your risk factor, okay? Fasting glucose, less than 100 is normal, so 100 or 125 is pre-diabetic, with 125 and above being diabetic. They're gonna scale these, okay? And which ones up here do you think are most important? Number 1. This is called coronary risk stratification, okay?
Smoking.
It's probably 2.
History of CBD.
Family history is number 1, okay? Without question. If your parents have died of cardiovascular disease, you're likely to die of cardiovascular disease. So that's the number 1. I would say cigarette smoking, and probably blood pressure would be next, and then the lipids. Ironically enough, the obesity is far down the chain. There are plenty of people who are obese, have no problems whatsoever with their heart. Okay, so it is very low on that list, but it is up there. Okay? All right. Jordan loves the little things. Anyway, these are things that you should know. Absolute contraindications to participate in exercise testing. Significant change in resting ECG. Okay, we're going to talk a bunch about ECGs. I know you guys touched on it in pathology a little bit. Again, significant changes, right, from one to another. What is unstable angina? So chest pain we know is angina, but what is unstable?
It's not really progressed.
Doesn't it not go away?
It's not really progressed.
No real pattern to it. So we know if someone who has chest pains every time they exercise at a certain level, that's stable, okay? They've been ruled out of having an MI, all that type of thing. But if someone just wakes up one morning with chest pain, that's unstable. Nothing triggered that we can come up with, okay? That's gonna be important. You cannot put them on a treadmill, okay? Uncontrolled dysrhythmias, that kind of goes without saying. And symptomatic heart failure, again, we can't put these people at risk. Acute pulmonary embolism or pulmonary infarction, again, that's common sense. We're not doing that. Acute myocarditis or pericarditis, so that's inflammation around the heart, okay? If you've got that, you can't test them. Symptomatic severe aortic stenosis. I don't even know how you test for this. I'm sure there's an ultrasound that they can do for something like that. But again, that is a contraindication. No dissecting aneurysm, that makes sense. Acute systemic infection. Anytime you go to these things, they're going to ask you right away, are you on antibiotics? Because if you're on antibiotics, they're not going to let you test. Okay? How do you feel today? That's always a good question too with these. So here's some relative contraindications. Okay? These are not absolutes, these are relative. Coronary artery stenosis, electrolyte abnormalities, and I don't know all of these. There's a bunch of a list of them that they would go through if they've got your blood gases and all your blood work and so forth, they can look at that. Stenotic valvular heart disease, again, moderate. Really hard to quantify that. There's ways to do that. You don't need to worry about it. Just know that that's part of the exclusionary process. Severe arterial hypertension at rest. You're not putting somebody, this would be an absolute for me, not putting somebody with 200 on a treadmill to test. Diastolic 110, I have seen people do that. I don't know that I would do that. Hypertrophic cardiomyopathy, okay? We talked about this the other day, especially the left side, because it has to work so hard. The cardiac muscle gets thicker, hypertrophy, and because it's thicker and it's less pliable, it doesn't pump as well, okay? And this, again, can be undiagnosed in a lot of folks. So that one's really hard to quantify. I think they do this under echo, but I'm not 100% sure. But just know that that's certainly a problem, and it's difficult to diagnose. Diabetes, I'm probably not going to put somebody who's fully diabetic on a stress test, but yeah, this doesn't list as that. Here we go for stopping. All right, so you got the person on the treadmill, and they they have chest pains. We're stopping the test. And number two kind of goes right along with that. If they've got chest pains, you need to rule out MI. Okay. Here's where it gets a little trickier. A drop in systolic more than 10 millimeters with increased work rate. Okay. So something's amiss, because their systolic should continue to rise, okay, until they get to their quote max. If it starts dropping, you need to stop this test. Something's wrong, okay? If systolic pressure gets above 250, I'm not even close to that. I would probably say 220, or if diastolic goes above 115. Again, a lot of these people are hooked up to 12-lead EKG, so you can check for arrhythmias and so forth as well at the same time. That would certainly be an automatic stop. Or if they have CNS symptoms. If somebody is confused, if they are not answering your questions, you are to stop exercise testing. Then there's the observation types of things. If you see that they're turning blue, the skin gets cold and clammy, okay? Those are not good things. Stop the test. Shortness of breath, wheezing, leg cramps, claudication, all stoppages. If you've got technical inabilities monitoring the ECG, you have to stop. Or if the patient refuses to continue, which happens more than you would ever imagine. A lot of these people do not like to be pushed. They will tell you, I'm not going any further. You can't go against them. Here's some relative contraindications to stopping. Failure of heart rate to increase with increasing intensity. It may not just be enough there, so you gotta weigh that out a little bit. Change in heart rhythm, you're gonna be watching that. If they request to stop, now, what is your job? Potentially, your job is to encourage them to continue, okay? So if they request to stop, you don't automatically stop. You say, do you have a little more? Do you have a little more? You're a cheerleader in this whole thing, okay? But if they say, I need to stop, then you have to respect that. Again, testing equipment can go. You cannot have somebody in an exercise testing, a formal exercise test, and have faulty equipment. If you've got faulty equipment, you would be liable for what's going on there, okay? So stop the test. All right. So this physical activity readiness questionnaire, the PAR-Q, these are self-guided reports that they can complete that gives them guidelines through all this, okay? Obviously, there's professionally guided through physician clearance and all that kind of thing, but that part test, I have seen that on a board exam. All it's asking you is you know what it is, for the most part. If this, again, a self-guided report, something that they do subjectively, indicates, hey, you're good to exercise. That's all it's saying. Okay? And it's a pretty lengthy thing, asking all those things, questions that we had talked about previously. Like this. Okay? And if you want to look at the full test, you're welcome to do so. All right, so let's look at a couple definitions of what you'll see when you look further into testing. VO2 max, the maximum rate of oxygen consumption by the body during maximal exercise. The key there being maximal exercise. You got to get them to that point. Okay? Now, there are lots of ways to extrapolate this. And we'll talk about these things. All these different protocols, the treadmill, the bike, all that type of thing. So you don't have to get them to max. You can get them to 70% of their max, and then you can extrapolate and say, this is what you would be if you would have pushed it the rest of the way. Okay? Versus VO2 peak. This is at maximum effort. Again, it's rare that you get to that point. Okay? Doesn't happen very often. Sometimes it does, though. You'd be surprised. So a submaximal test, what I was just referring to, they achieve a predetermined exertional level and the test is stopped. It could be symptom related or it could have a predetermined endpoint. Okay? It is a ramped progressive protocol. Okay? There is no gas analysis performed. You're only taking vitals and things are extrapolated. Okay? So we've talked about this board scale, 6 to 20. This is how this works. You would put somebody on the treadmill at stage 1, and they would walk. Notice the gradient. It's very aggressive, okay? But the speed is manageable, at least at the beginning. But as this goes up, and every 3 minutes, you get an increase in speed and gradient, okay? Modified Bruce protocol, okay, for the bike. This is still treadmill, excuse me, I'm sorry. So what do we derive from the test if we're not taking actual VO2 max readings? We look at the stage, we look at the duration, we know that there's certain fixed workloads at every given stage, and then you start looking at it on a graph. You can estimate their VO2 max. Again, do not worry about the math. Not worried about this math. Okay? This is what you do. You plug all this in, it gives you a rating. And then you can rate them from very poor to superior. These are females, ages, where are they should be at their peak? Females mature earlier, right? So younger, they're going to be at peak at around 19, okay, as opposed to the guys, 20 to 29. Okay. So again, I would know some general values here. Do not commit this chart to memory. General values. So we get these results. What do? Well, we can convert the VO2 max to METs by dividing it by 3.5. Okay, not worried about the math. I'll tell you when we need some math. And then this is just like anything else. You take a before, you take a during, and you take an after. And you can justify cardiac rehab to a third-party payer. Okay? Document progress, you have to do it. All right, anybody seen or administered a 6-minute walk test before? Okay. Really, really simple, super simple. Definitely something that you will see PTAs doing. Okay, let's go through the steps here with that. Again, very, very simple, requires a 100-foot hallway, but no equipment or advanced training. You're just gonna measure the distance that the patient can quickly walk on this flat, hard surface for a period of 6 minutes. Simple. Self-paced, and assesses the sub-max level of functional capacity. Insurance companies know about this test, is what I'm saying. Okay? So, you rest quietly for 10 minutes. You get all their resting, physiological vitals and so forth. Yes, ma'am?
Can you do this with people who have like assistive devices?
Yes, you can, and it talks about that. Absolutely. Absolutely. The patient may rest during this. Now, Rebecca, did you guys give them chairs to sit in?
Only if necessary, we always had a chair like standby.
You have a chair standby,
Yeah.
but you didn't follow them along the wheelchair or anything like that. Okay, that's kind of the way we did things too. We had things in emergency, obviously, if someone fall out, whatever. But at the same time, you're not encouraging them to sit down and rest. A lot of people had these, when we did this test, they had the rollators. You guys know what those look like, right? And you can lock that, turn around, sit down. That's great. That's the perfect thing to have for this. Okay. It's very standardized in the instructions. You read verbatim every single time you do the same test. Okay. And it's out and back, and you'll set up cones and so forth. The outcome is the distance walk. Okay. Really, really simple. You will limit your conversation. Practice test is not needed. You can give them one. A little controversial whether you should do that or not. But again, it's just walking. Nothing dramatic about it. They may use oxygen during the test. If they've got a canister that they have or some kind of portable oxygen that can be used. You just need to document that. Because you may want to try to wean them off of that. So here's your required equipment. Obviously a stopwatch. You do not need a mechanical lap counter. I hope you can count. 2 cones, mark the turnaround points at the 100 foot mark. A chair that can be moved. Some kind of clipboard. Oxygen if you need it. And then your BP cuff. A telephone. AED. Pulse oximeter. Pretty standard. Alright? This is what you would do at baseline and at the end of the test. Using board scale. RPE, before and after. Rate of breathlessness. Did we talk about board scale for dyspnea as well? They do that on a 0 to 10 scale. Okay, rates your shortness of breath. So now you've got this figure. Again, you know, guys, do not worry about the math and so forth. But let's say you come up with meters walked. Okay, you're going to put these into these categories here, and you will be able to extrapolate that. Again, do not worry about all that. What you're looking for. Put it in the graph, and it's all good. Right? Last year's class had to do these on a weekly basis. That's why they're labeled as weeks.
Would you warm them up before get the heart rate up? Or just do it?
No. Our protocol was, again, a lot of these people are really deconditioned. So if they had to get into the hallway, come up the elevator, or whatever it was, they're pretty fatigued. So we would sit them down for 10 minutes. We'd take all their vitals and stuff until those were stabilized, and then we would go. You'd be amazed, 6 minutes wear these people out, so, yeah. It's fun though, because you see dramatic improvement in this. I mean, dramatic improvement. You will see, we used to do these every, I think it was 2 weeks. It was incredible. Absolutely amazing how much improvement these people make. Some of these people just have never exercised in their life, you know. It's staggering how deconditioned they would be. Any questions on that 6-minute stuff? That's the biggest thing I wanted you to grab from that. Yes, sir.
The little handout you have for it talks about how a lot of them are done twice, before and after, they're. So, when you're doing that, with people, how important is the board scale before, like, that first test and then the second test?
So, again, the way we would do it is they would come straight from, if they were inpatient, they came straight from their room. So, you know, right away. If they're doing their exercises afterward and so forth, we would certainly scale things down a little bit. Because again, usually the 6 minutes would wear them out pretty good.
Could you count that as like a warm-up?
I guess you could. I can't remember how we did that, to be honest with you.
Okay.
Yeah. Yeah, we had a gym about as big as this whole room. And we had probably 3 to 4 treadmills, a couple arm bikes, several recumbent bikes. We had like some free weights, pretty similar to the way this thing is, just a little bit more equipment. And we would probably have 8 to 10 people at a time. And they would come in, and we check all their vitals. You have to have a bunch of techs doing this kind of stuff to really be efficient with it. And then they would go and do 5 minutes of UBE. They would do we had 5-minute stations essentially. And, we would stretch. We'd have to do 5 minutes of something, we would stretch. And we would do some type of just really simple stuff with like, squats, heel raises, arm circles. Just, again, these are very deconditioned people. That wears them out. Then you'd have a little rest period. You'd take vitals again. Then you'd switch. If they started on one, they'd go to the next station. It was really very, very simple and very regimented how we did it. And they had their little flow sheets, everybody had their little thing, and you just check them off and go. There wasn't, I wouldn't say a whole lot of clinical decision making that went on, but the PT would come in, he wasn't even there. I mean, the only people that were in there was one nurse, myself as a student, and 2 or 3 techs taking vitals. So, not a lot going on there. And then the PT would take and look at the flow sheets at everybody and say, oh, look at the improvement they're making. But this one's breathing really hard, they've got to scale this back. Not real hard, not real hard. I found it really fascinating to watch how they improved though. Very encouraging to me. Come on. All right, so second part to exercise testing. What do we do with these results? This is kind of what we were just talking about. So we have to have these results to be able to safely progress these folks, okay? The guidelines that the American College of Sports Medicine has really come up with is avoiding inactivity. So again, most of these people just sit around, eat, drink, smoke, whatever. You gotta get them up and moving. So the guidelines are 150 minutes a week of moderate intensity exercise. What was moderate? You remember? We talked about this.
50%.
For example.
What activities were moderate activities?
Like walking to a certain speed.
Walking.
Yeah.
Walking. We're not talking about dramatic types of stuff here, okay? What would be vigorous?
Jogging.
Running, cycling, all those types of things, okay? So this is very basic for everybody. If we can get them into this, great, right? 300 minutes a week for additional health benefits. Obviously, it makes sense. The more we can do, the better off they're gonna be. Strengthening activities 2 or more days a week. The minimum. And again, that may be something as simple as body weight squats, planks, some type of modified push-up, okay? They might not be able to do any of those. Maybe be sitting there doing curls with 2-pound weights. Whatever it is, get them to do something. And be an advocate for it, okay? Encourage, encourage, encourage. Again, just statements from the HHS. All common sense. If you cannot do 150 minutes of moderate per week, be as physically active as your abilities allow. Do something. Just because you can't do 150, don't go home and do, I can't do it, and do nothing. Okay? Do 120 if that's what you can do. Encourage this, people. Encourage it. Should do exercises to maintain improved balance if they're at risk for falls. We've talked a lot about balance in here. Okay? All kinds of things that we can do to encourage that. All right, so here's at-home activities. This is a great slide, because this kind of gives you some ability to say, okay, they're at home. They're doing some light vacuuming or sweeping things up a little bit. This is where they're at.
So weird.
Which one are we laughing at?
Who
Sweeping
sweeps the
the
carpet?
Who does that?
So, you know, it looks like a little vacuum thing.
That's
Sweep
sweeping,
carpet.
vacuuming.
Moving furniture. Don't do that. That creates business.
She's got good form, so maybe not.
All right, so here's more formal exercise. Look at running a 9-minute mile, which is not really fast. It's 11 minutes. It's a lot. Swimming, excellent. 8.0, great exercise. Creates so many shoulder problems, keeps the outpatient in business. All right, so again, we've already talked about this today once. Here's the FIT principle again. Things that you can control. So when I've got 13 questions on exercise prescription up here, this is the kind of stuff. How are you going to manipulate it? Okay, what's the most correct or most appropriate way to adjust this given this patient scenario? That's board questions. That's what you're going to see. You can do this, people. This is common sense. You just have to reason through it. Okay? What's the giggles about? Just have to agree. You just have to agree with me. That's all it is. More of the moderate, vigorous, etc. Again, 3 to 5 is a good rule of thumb there. So if you've got somebody who is really deconditioned, we talked about this. Break it up into short periods of time. We don't expect them to exercise 30 minutes at a time. But the 2-minute commercial breaks when they're watching TV, sit to stands, heel raises, marching in place. Go just walk around the house the whole time the commercial's on. Whatever that might be, okay? Whatever you can do to get them up. Keep it in mind. And always promote it. So the intensity part, okay, we can measure it a bunch of different ways. We've talked about VO2 max, wearing a mask, actually getting blood gases. We've talked about estimating this. We've talked about estimating heart rate maximum, okay, percentage of your heart rate max. Percentage of estimated heart rate reserve. That's a little more complex, don't worry about that right now. 6-minute walk test we just finished talking about. Getting their rated perceived exertion to this 12 to 14, which should correlate to 120 to 140 beats per minute, or 5 to 6 on the dyspnea scale. Another way to do it is through a percentage of 1 repetition maximum if you're doing resistive work. There's lots of different ways to document and alter intensity. This is the graph that you should see. Again, there's Borg again. This is the modified Borg. You'll see this, start to see this a little bit more. So people don't like the 6 to 20, so they've got it to a 1 to 10 scale now. I like the 6 to 20, I think it makes sense.
So,
Numbers needed to estimate, again, we need their max, we need their reserve, or their target. We've talked about estimating max, 220 minus the age. This is a little bit different method. It's a little bit more aggressive than 220 minus age. If you remember 220 minus age, you're gonna be fine. You're gonna be fine. All right, heart rate reserve. We're gonna talk a little bit about that now. The range in which your heart can vary. So we've got a resting pulse, right? Let's say it's 60. And let's say you guys, one of you is 20 years old, and your predicted max would be 200. 220 minus the age. And then we subtract your resting. So your heart rate reserve would then be 140. The difference between the age predicted and your maximum heart rate. That is something you need to know.
So are you just supposed to stay in your range? Like, what's the purpose of going?
Well, we're gonna use this figure to derive some other things. But that's just a definition that you should know. So we can estimate that. I don't know why you would, it's not that hard to just figure it out. We can adjust intensity based on a percentage of this heart rate range. And it now yields the target heart rate range. Okay, just another way to adjust intensity. And again, you've got light, moderate, and high here. 30 to 40% of this, 40 to 60 for moderate, and 60 to 90 for high intensity. And notice how the rate of preserved exertion on a 1 to 10 scale correlates with this. Okay. Boards like to try to trick you. They'll give you something like 40 to 60% of this, and then they'll give you a board scale that won't match. And you need to be able to identify that. Okay. So moderate intensity, 40 to 60. We've got that heart rate reserve, our 75-year-old man. So again, that's 220 minus 75. Take away their resting at 72 beats per minute. So their target for 40 to 60 would be 104 to 121. I know that's a lot of math. Don't think you need a calculator for any of that. And again, you can use meds as well. We've talked enough about the meds. I feel like you guys can manage that okay. Look at examples. Factors affecting intensity. Obviously, age, goals, exercise capabilities, their experience, you know? Health status and fitness levels for sure. Sedentary history. If they've had some type of myocardial infarction, history of, even something with just chest pain, that's going to affect this. So again, exercise mode, common sense, what is available? In here, we've got what? 1, 2, 3, and resisted work that can count as exercise. We've got 4 different methods, right? What do they have available to them? If you're discharging them, You need to be able to know, hey, they're going to Planet Fitness. I know exactly what they have there. Okay? Get yourself, if you're in that type of field, you need to know what every gym, YMCA, whatever, has available. Because people will get very confused just because their bike looks completely different. And they'll be hesitant to go use it. Treadmills usually don't intimidate people. Bikes, UBEs, things like that, they get freaked out because it does not the same main brand or the same setup or whatever, right? That's your job. Always encourage aerobic and strength training, not either. They need both. We've talked about large muscle groups, walking, cycling, swimming, tennis, pickleball. Those all kind of fit in that moderate range, right? But those at-home activities, gardening, playing with their grandkids, whatever the case may be there, can help that, can supplement that. But there's the key right here. They've got to enjoy it. That's why if people do not like going to the gym, don't push it. Get them to walk around, get them in the neighborhood with a friend, keeps them accountable. All that's important. Just for curiosity, how many of your grandparents go to a gym at all? So 2 out of 23, okay? My parents, my dad will go occasionally, he doesn't like going. My mom can't stand it. She'll go to a pool and do an aquatic exercise program. You gotta find what they like. Because compliance is that's the only thing that matters there. Okay? This is a good break. Let's take a break. Check on one thing. So let's say 10:30, so a little bit longer. Yes, sir.